and it increases the prognosis for metastatic GTN. So hysterectomy is done if the lesion is confined to the uterus in women aged more than 35 years and they are not desirous of fertility. In placental site trophoblastic tumor and epithelioid trophoblastic tumor, as it is resistant to chemotherapy, so hysterectomy is the primary modality for the treatment. In localized uterine region, which is resistant to chemotherapy, we can do a local uterine dissection in patients who want fertility and hysterectomy in patients who do not want fertility. In cases of accidental uterine perforation during curettage, or to control uterine hemorrhage or sepsis in metastatic disease. So this is the monitoring regimen for high-risk GTN. In high-risk GTN, we give combination chemotherapy, and as discussed in brain metastasis, we have to increase the methotrexate and folinic acid dose, and we can give whole brain irradiation or stereotactic radiotherapy. We have to do 2 weekly HCG values during the treatment. If the HCG values are normal, then we continue chemotherapy for 3 more cycles, and HCG assay is done every month for 12 months. In stage 4, the HCG, the follow-up for HCG is for 24 months. If there is good response to the initial chemotherapy, but it is followed by plateau or relapse, then we have to switch the regimen to EMA-EP or EP-EMA. If there is incomplete response to treatment, then etoposide-based regimen with bleomycin or paclitaxel or platinum-based regimen is considered. And we can also give resection if feasible. So here are the various definitions. It is said to be disease is said to be remission if there are 3 consecutive normal HB values. It is said to have a response when there is more than 10% decline in the HG during one treatment cycle. Plateau if it is more plus minus 10% during in the HCG during one cycle. Resistant if there is 10% rise during one cycle or plateau for 2 cycles of chemotherapy. And the cure is almost 100% in low risk and 70% in high risk. And the recurrence risk of non-metastatic GTN is 2 to 3%. Low risk metastatic risk is 3 to 5%. And if they have poor prognostic factors, then the recurrence risk is 21%. So in the management of refractory GTN, we give a platinum-based chemotherapy with cisplatin, vinblastine, bleomycin, ifosfamide or paclitaxel. They can also be used, but further studies are needed. And there is a potential role of autologous bone marrow transplantation or stem cell rescue in conjunction with ultra high dose chemo. It is yet to be defined. So pregnancies after uncomplicated hydatidiform mole, they can anticipate normal reproduction, and they should be reassured that there is no increased risk of complications in later pregnancy. But they should be informed of the increased risk of having molar in subsequent pregnancies. As we previously read, in complete mole, the risk is up to 15%, and in partial mole, it is 1 to 5%. So for any subsequent pregnancies, we have to tell them to get a pelvic ultrasound during the first trimester to confirm a normal gestational development. And we have to obtain their HCG measurements 6 weeks after completion of pregnancy to exclude any occult trophoblastic neoplasia. And in pregnancies after GTN, if the GTN is treated successfully and if they do not conceive for 1 year, they have good outcomes of pregnancy and reproduction, and there is no effect on the subsequent pregnancy. So these are the alternative regimens or the salvage therapy, which include EMA-EP, PVP, PETP, that is paclitaxel and etoposide and cisplatin. Immunotherapy with pembrolizumab has also a role. In ultra high risk GTN, it is recently defined in FICO 2021. It is for those patients with massive disease, that is having liver, brain or extensive met, with prognostic score more than equal to 13. Starting with standard chemotherapy may lead to sudden tumor collapse with severe bleeding, metabolic acidosis, myelosuppression, septicemia or multi-organ failure, any or all of which can result in early death. So to avoid this, The use of initial gentle rather than full dose chemotherapy should be done. That is induction with etoposide 100 mg per meter square and cisplatin 20 mg per meter square is done on day 1 and 2, and it is repeated every weekly for 3 weeks before starting the standard full dose chemotherapy, as it has appeared to have eliminated early deaths. For contraception, patients are encouraged to use effective contraception during the entire follow-up of beta-HCG and 12 months after the normal values of HCG. In stage 4, the patient is advised to be for follow-up and use contraception for 2 years. IUCDs are not inserted unless the patient achieves a normal HCG level, as it increases the risk of perforation, bleeding, and sepsis. Oral contraceptions are preferred because they suppress the endogenous LH and FSH, which may interfere with the HCG measurement at low levels. And DMPA can also be used. However, barium methods are not recommended because they have high failure rate. Thank you.
Very well presented, Guneet. Barman sir?
Yes. Congratulations. I think it's you have covered almost everything. So I think I will look for the in the chat box if there is any question. I have a question. Actually, can you predict the resistance of methotrexate based on ultrasonographic finding? Anything? Do you know any studies?
Sir, pardon, sir, please.
Yeah, and there are few studies where they have predicted the resistance to methotrexate in a case of GTN based on ultrasound Doppler studies.
Okay. So right, I have not read.
Yeah, so they have found that if the predictive PI is less than 1 or 1.5, then these are the patients where they may encounter resistance to methotrexate. Isn't it, Dr. Sima?
Yes, sir. Recently there are a lot of studies on this. Very nice, sir.
Yeah, this is on. Yes. I think actually she has included many things, almost everything.
Yeah.
I think this one she didn't include because it was very excellent presentation.
Yeah.
You have almost included everything. Any secondary metastasis that you encounter after treatment for choriocarcinoma or GTN?
The secondary metastasis can occur in
secondary carcinoma, I think.
Not secondary carcinoma.
Yeah.
After GTN.
Yeah.
Sir, I haven't gone to any such case.
Yeah, AML, they say that they're almost 20 to 30% of the patient you may get, especially when you treat them with the high doses chemotherapy, multi-agent chemotherapy, you may encounter AML, and also I think liver cancer and breast cancer also something, and any other malignancy apart from GTN where you get high beta HCG. It may be gynecological or non-gynecological.
Okay. So blood cancers can occur due to this macro regimen.
That is the secondary malignancy. Any other malignancy where you have reached beta HCG?
Beta HCG, Dr. Guneet, beta HCG secreting tumors, what can they do?
Okay.
Yeah.
Beta HCG secreting tumors can occur, so they are very rare, but they can occur in ovary also.
Yeah. And ovary, which varieties?
In which type of ovarian tumor, sir?
Yeah, which type of ovarian cancers do you have raised beta HCG?
Yeah.
Sir, in germ cells, we can have raised beta HCG.
Polyembryoma, Histaminum also sometimes. Sometimes you get this, no? And even some non-gynecological cancers also sometimes. Especially the bone tumors, sometimes they say.
So in the chat box, there's a reply to your question, sir. The students have answered germ cell, mediastinal GCT, and embryonal carcinomas. So and in these patients where we can have
you can have
these beta HCGs.
There is another question, Dr. Guneet. Would you want to answer this? How to diagnose choriocarcinoma after normal gestation versus spontaneous abortion, as they present with bleeding? RBOC may not be tested. I think Dr. Guneet had already said. Guneet? Dr. Guneet?
Yes, ma'am. Ma'am, for choriocarcinoma, after a normal gestation, like after a term pregnancy, if there is still an elevated level of HCG, even after any normal pregnancy, it should be labeled as choriocarcinoma unless proven otherwise. While for spontaneous abortion, we have the in spontaneous abortion also they present with like as you said they present with bleeding. So we test for their beta HCG, and if it's elevated, then we label it as DTN.
Yes. Yeah. I think the question has been answered. Anything else?
Who started IMACO? You know, who was the first to start this regime?
IMACO.
That I think Dr. Guneet will not be aware. Medical.
She has done very good. That's why I'm asking this question.
Yeah. Medical oncology, I think would know because most of the time, at least in our institute,
students have answered here. Students have answered.
Okay, students have answered. Backshaw, yes.
Backshaw. Yeah.
I just thought Dr. Guneet would not know.
Backshaw. Okay.
So now Dr. Bhagya ma'am has said that non-gestational choriocarcinoma, hepatocellular carcinoma. There also you will find raised beta HCGs despite having non-GTN. Thank you, ma'am. Then we have how to manage coexisting twins and molar.
For coexisting twin and molar, we have to counsel the patient that there is very increased risk of further malignancy in this patient. So we advise for medical termination of pregnancy in these cases, and continuation of pregnancy is not it is not considered safe. So we have to counsel the patient for MTP, and so we have to counsel because there is increased risk of 20% in these cases with coexistent twin.
So I think the chat box has almost answered everything.
There's another question: what if it is precious pregnancy with twin molar? I mean, these conditions.
What if it is a precious pregnancy with twin molar? With twin molar.
Still, we have to advise for termination.
Yeah, you have to counsel them and tell them, right?
Yes.
That it is increased risk.
So these situations would exist. I mean, like you have to tailor the therapy. Can understand if you have to counsel the patients always in all the situations. For example, Vishal has written, "Why not early hysterectomy?" For example, if the family is completed at 25 years. Number one, how many patients would have completed their family at 25 years? And then another thing is, even if they've completed just 1-year-old baby, I mean, just don't go away with the hysterectomy straight away. It's not the solution. But another thing is, see, this kind of questions will keep on arising. You have to tailor therapy because these are the scenarios which anything can happen, anything can be created into a scenario. So it's okay to understand that. So depending on the situation of the patient, depending on the requirements of the patients, you will take the decisions.
Yes, I think very rightly said by Dr. Seema. You have to individualize the treatments once in a while. Like Dr. Guneet had put a cutoff of hysterectomy as 35 if family completed. But I mean, again, you have to tailor. Somebody would want a baby maybe at 35 because these days we see a lot of late marriages, late babies. You actually have to individualize treatments in such cases. If somebody has completed at 30 years, maybe you can go ahead also. So yes, individualization of treatment, counseling is very, very important. This is something which I think we should do. Thank you. I think Dr. Guneet, that was a wonderful presentation.
Yeah.
Very good. Very elaborate. I think you have not left anything. And one very important thing which I would want you to emphasize is the phantom HCG. There are times when we...
Dr. Rashmi seems to have lost her connection. We lost you, Dr. Rashmi.
I think Bhagya ma'am
lost
her.
Pregnancy that we have to tell her to get an early ultrasound, and we have to tell her to meet the gynecologist or obstetrician as early as possible. And after her pregnancy ends, she has to do her beta HCG 6 weeks after the pregnancy to rule out any occult GTN. So we have to counsel her for her next pregnancy, and we have to tell her to follow the contraception strictly during the follow-up period, which is for complete more for 6 months, for low risk patients 1 year, and for high risk patients it is 2 years. So we have to tell her to follow the contraception like strictly.
Yeah. So appropriate, like for the patients who are presenting with the first trimester pregnancies, having problems bleeding, so molar pregnancy should be kept